I'll jump straight to my talk. And so the challenges, typically, even when there is a dry eye disease, is not just limited to the choice of IOL or the type of cataract surgery, but also begin right before that is the inaccurate biometry, deficient media clarity because of the scarring and variable thinning. And also, there is a worry about exacerbation of underlying immunoetiology, especially in cases like Stevens Johnson's or OCP. Now, the series of inflammatory events which are initiated by the surgical trauma of cataract surgery may also lead to corneal melts and perforation. Now, pre-operative, the nuances include in the lids we can see meibomian gland dysfunction, which possibly could lead to secondary infection post surgery because we are going to be giving steroids. Malposition of the lids may be pre-existing, which may lead to an epithelial defect, again interfering with our use of steroids. Pre-existent trichiasis, entropion, ectropion may also lead to secondary infections, as well as presence of lid margin keratinization. Now, presence of aqueous tear deficiency, the tear film may be inadequate, and this may lead to a presence of punctate epithelial erosions or a non-healing epithelial defect, and it may predispose to secondary infections. Fornical shortening, as seen in SJS or OCP, we may need to rule out the underlying immune etiology and address the fornical shortening only if it is going to interfere with cataract surgery. In other situations where the fornical shortening or presence of symblepharon will be addressed before cataract surgery is if we are planning that the patient is having a scar and we would want to use a scleral contact lens post-operatively for addressing the same. So this is a case of severe dry eye disease with peripheral. There is some scarring, and there is a central very faint nebular macular grade haze. As we see over the course of the cataract surgery, sometimes these scars tend to become larger and more opaque, making the surgery, which seemed very straightforward or only slightly challenging, to become more and more challenging. So this case we have planned for a small incision cataract surgery because the density of the cataract was very high, and also because the scar is central, and also there is some presence of peripheral scarring. Uh, During the preparation, topical paracaine was also instilled inadvertently, although I prefer in all these cases to operate only under peribulbar block. Therefore, while inserting the speculum, the epithelium had become loose and had to be removed. However, it must be noted that we must preserve the epithelium as much as possible in these cases. I'm using the red glow over here because the pupil is slightly larger than the central scar in order to make the rexis. And as Dr. Tate has very well, beautifully elaborated on how to make the rexis in the presence of such a scar, I'll skip this area. However, it's important to note that we need not stick to or make it an ego issue to make a rexis. You can always convert to a can opener technique, especially when you have already planned for a three-piece lens. It is preferable to make the entry and plan your tunnel in a non-scarred area and an area which is not thin. In the For cortical aspiration also, it is better to use chandelier type of illumination in order to make it easier. As we can see, the cases become slightly more hazy, and the presence of an external illumination source is making it much easier, although not faster, to remove the cortical matter. Three-piece lens is then placed it is aimed to be placed either in the bag or in the sulcus, especially because we know that there may be tags. If the cortical matter edges are still visible, then we can go ahead and repeat the chandelier illumination and repeat the cortical aspiration even after placing the lens. It is important in irregular or scarred corneas, and especially in dry eye disease where we have planned an SICS. Even if your tunnel is well sealed, it is better to put a suture. So these are some of the points which I mentioned. Prophylactic topical antibiotics are also preferred because we must remember that in dry eye disease, the surface commensals are already altered, and therefore we need to use topical. It's preferable to use topical antibiotics. Local anesthesia or general anesthesia, if required, may be preferred, and as compared to a topical one. It is important to inform the staff not to excessively irrigate or use excessive light because these patients are already photophobic. Prefer clear corneal if phacoemulsification if it is possible, or if required, as seen, can perform SICS or ECC. Choice of incision should depend on the location of the scar, if at all, and coat the cornea with viscoelastic if required. These points we have already discussed. Also, what we didn't see in the video was preference of optical iridectomy if it indicated, if we feel that the visual acuity, dilated visual acuity preoperatively was better. Reduce the use of NSAIDs postoperatively. Now, specific points about aqueous deficiency. Investigate for the cause of aqueous deficiency before the surgery. If you are suspecting Sjogren's, it's better to refer to a rheumatologist before taking up even elective cataract surgery, because if the condition is in remission or is having low disease activity, then the question doesn't arise. But however, if it is not and it is very active, then immunomodulator or DMARDs may be stepped up as required. An emergency cataract surgery may warrant preoperative steroids. Treatment with topical autologous serum is also preferred. In SJS, typically punctal occlusion makes a lot of difference. The other parts such as lid margin keratinization can be corrected surgically, either with lenses, pros lenses, or with mucous membrane grafting, and fornical shortening, as mentioned before, can be managed. This is another challenging case wherein there was a total cataract and the patient was having repeated perforations in a case of SJS. You can see the lid margin keratinization over here, and which is recurring, and there is a presence of a mucous membrane graft which had been done prior. This patient continued to perforate until we removed the cataract with the help of phacoaspiration, and then repeated the multi-layered amniotic membrane grafting. Post this, she improved tremendously, and the perforation did not recur. Now, post-operatively, what are the challenges? Despite adequate condition of control of the systemic condition, also there can be worsening of the dry eye symptoms themselves. Therefore, we need to remember to include in our regimen of post-operative cataract surgeries more frequent lubricants. Corneal defects, melts or infections may still occur, and therefore a more frequent follow-up is preferred. PTK or PTK alone or with PRK can be performed in very, very select cases, very, very rarely, to correct the minimal residual refractive error. And very cautious use of RGP or contact lenses also can be done in cases of emetropia, where the patient is very compliant. Scleral contact lenses can be preferred, especially in post-cataract surgeries, patients with Stevens-Johnson syndrome, to improve both the comfort and also the visual acuity for dry eyes and for the management of the corneal scars. Thank you very much.